My name is Dzuba, and I have been invited to talk to you today about a subject touching on sex. What I will discuss today has both a technical or professional aspect as well as a personal one. The broader subject that I am addressing is sexual stigma and the role that it plays in public health. I'll first tell you a little bit more about myself and how this subject came to be of interest to me, and then I'll speak to a handful of concrete examples of how the hidden role of sexual stigma contributes to some serious negative consequences to the health and well-being of many people. As well, I will also speak to how we can identify stigmatizing behavior and address this in our personal and professional lives. So let me begin by telling you a little bit more about myself as a professional and why this subject of stigma is important to me. I'm a researcher who works for a national public health agency, and I've been working more broadly in the public health research sector for close to 10 years. Over the course of this decade, I've had a lot, and I mean a lot, of statistics come across my desk as part of my work. Whether the subject is on the uptake of vaccines or public health advice, the factors that contribute to contracting diseases or that have an influence on substance misuse disorders, what we in the public health realm used to call drug addiction, there are persistent inequities in what is happening to different groups of people. One of these groups is sexual identity, and the causes of the inequities has to do with how those groups are treated by society and public health officials. And this is where stigma factors in. So what is stigma and how does it impact the health of individuals and groups? Although public health policies and programs should benefit everyone, persistent health inequities prevent many from being able to achieve their full potential. Often these differences can be explained by how people are treated, and this is where stigma comes into play. Within the public health world, in its most basic form, stigma is the insidious practice of dehumanizing others. This is what we know. Stigma is associated with poor physical and mental health outcomes. Stigma and discrimination towards persons with health conditions, such as mental illness, substance use disorders, and HIV, cannot be understood or treated separately from stigma related to other characteristics such as race, gender, sexual orientation, age, and income. These many forms of stigma that intersect in complex ways are very much present in our health system, driving those most in need from getting effective care and accessing services away from the health system. It means that we as a health system leaders and practitioners are contributing to negative health outcomes. Health inequalities reflect differences in health outcomes. When these differences are related to unfair conditions, they are called health inequities. When reporting on populations that experience a disproportionate burden of poor health outcomes, it is critical to understand the context of this data. Some Canadians experience worse social and health outcomes than others. The evidence tells us that this is, in part, due to how we treat each other. When we stigmatize people, we affect their chances for a long and healthy life. Different types of stigma can intersect and work interactively to affect health. Researchers use the term intersectionality to understand the complex connections, outcomes, and opportunities that can arise when people are subjected to multiple forms of stigma. For example, the discrimination experienced by a racialized gay man living with HIV could produce poorer health outcomes because of the stigmas that arise from being racialized, identifying as gay, and living with HIV. Poorer outcomes might also result for an Indigenous two-spirited person living with a mental illness. The reality is that many Canadians live with multiple stigmas. A key benefit of an intersectional approach is that it embeds an understanding of this complexity in our understanding of stigma's impact on health, and can therefore lead to a more complete and impactful response in addressing health consequences. The following examples of how different factors intersect with health issues will help to underline the role that stigma can play and how different factors can intersect to have different impacts. Mental health varies considerably among Canadians, with some subpopulations being more likely to report low self-rated mental health. For example, for the period of 2010 to 2013, adults who identified as bisexual were close to 3 times more likely to report negative mental health, and adults who identified as gay or lesbian were approximately twice as more likely to report low-rated, self-rated mental health than adults who identified as heterosexual. These higher rates could be linked to internalized stresses related to gender expectations and experienced discrimination. Sexually transmitted infections such as syphilis are also making a comeback with the additional challenge of antibiotic-resistant bacteria causing gonorrhea. While the number of newly diagnosed HIV infections remained relatively stable in Canada, 14% of people living with HIV were estimated to be unaware of their status in 2016. Similarly, as of 2016, national hepatitis C infection rates will remain stable over the course of the previous years. An estimated 44% of Canadians living with hepatitis C are thought to be unaware of their status. Now, some communities are disproportionately affected. For example, gay, bisexual, and other men who have sex with men accounted for more than 50% of new HIV infections in 2016, although they represented approximately 3% of the male population in Canada. Indigenous peoples accounted for 11% of new HIV infections in 2016, but represented only 5% of the general population. Certain subpopulations are at even higher risk for Hep C infections, such as people who injected drugs, who are incarcerated. Now I'll talk a little bit more about how stigma presents itself in and leads to negative health outcomes. Stigma affects health through stress and other physical pathways. Many people are exposed to multiple stigmas, preventing them from attaining the resources they need to achieve optimal health, such as education, employment, housing, and health services. Stigma in the health system can be particularly harmful, as people are prevented from accessing the health information and services and resources they need, creating mistrust and further exclusion. Stigma begins with a labeling of differences and negative stereotyping of people, creating a separation between us and them. Those who are stigmatized are devalued and subjected to discrimination, which is unjust treatment. This can lead to disadvantage and inequitable social and health outcomes. Stigma happens in institutions, for instance, healthcare organizations such as hospitals, at a population level, in the form of societal norms and values, through interpersonal relationships, in the form of mistreatment, and internally, of feelings of self-worth, value, feelings of shame and guilt. Stigma can be seen as both a cause and effect. It continues to justify the devaluing of people through stereotypes and exclusion. Unless the cycle is actively stopped, the separation into us and them is reinforced by unequal power dynamics in society. People and institutions with resources and power, including health organizations, shape laws and societal norms that can influence what is considered to be normal and acceptable. In the health system, this power dynamic also exists between healthcare providers and patients. I'll now speak a little bit more detail about how the experience of stigma leads to poorer outcomes and impacts overall health. Emerging research indicates that stigma affects health in three key ways. Number one, it reduces access to and quality of protective resources and health services. Secondly, it increases the risk of chronic stress and poor coping responses. And third of all, it puts stigmatized people at high risk of assault and injury. So what this looks like, when an individual experiences stigma, the reduced access to protective resources leads to poor living conditions and socioeconomic status, and it also leads to decreased access to and quality of health services. When this combines with the chronic stress faced by individuals experiencing stigma, these produce also psychological symptoms, negative coping behaviors, and physiological stress responses, all of which result in certain mental health outcomes, for instance, anxiety, depression, suicide, and self-harm. It also results in certain physical health outcomes, for instance, cardiovascular disease, decreased birth weights, increased blood pressure, physical injury, and an increased chance of contracting sexually transmitted and blood-borne infections. With respect to the third item, violence and assault, and these types of physical behaviors, these lead to, again, mental health outcomes, anxiety, depression, suicide, and self-harm, and they also result in physical health outcomes, in particular physical injury. Stigma can target different identities, characteristics, behaviors, practices, or health conditions. For example, stigma can be based on race, gender, and gender identity, sexual orientation, language, age, substance use, ability, and social class. Stigma related to health conditions can include obesity, substance use disorders, mental illness, dementia, tuberculosis, HIV infection. When stigmas intersect, they can exacerbate negative health outcomes. Stigma includes discrimination as enacted stigma. While there is little data measuring stigma in Canada, discrimination is more commonly measured. The following section summarizes available self-reported discrimination data for some key populations. It is important to note that there is limited data and that experiences of discrimination may be underreported. Over 1 in 4 Canadians have reported experiencing at least one form of discrimination in their lifetime. Many Canadians experience discrimination based on race, religion, ethnic origin, gender, or sexual orientation. The most common type of discrimination reported by Canadians is racial discrimination. African, Caribbean, and Black Canadians are the most likely to report discrimination in Canada, followed by Indigenous peoples. Alarmingly, hate crimes, one of the most extreme forms of discrimination, has been on the rise in Canada, primarily against people who are part of Arab, Muslim, Jewish, and Black communities. New analyses of the 2013 Canadian Community Health Survey Rapid Response Discrimination Module, the only national discrimination survey in Canada, support these findings. Lesbian, gay, bisexual participants, note that transgender identities were not included in this survey. African, Caribbean, and Black Canadians and Indigenous peoples in Canada were more likely to report being unfairly treated than the general population. More specifically, LGBT community members were almost 3 times more likely, and African, Caribbean, and Black Canadians and Indigenous peoples were twice as likely to report having faced discrimination than their general population counterparts. In a national Canadian survey, the majority of youth who identified as transgendered, those are youth being ages 19 to 25 years old, reported having experienced discrimination in the last year based on their gender identity, 70% of them, sex, 63% of them, physical appearance, 60% of them, or sexual orientation at 59%. Stigma imposes significant costs on society, although quantifying the direct economic cost of stigma remains a challenge. Researchers have examined productivity loss and the consumption of resources from experiencing stigma. On an individual level, stigma is a significant barrier to housing, employment, income improvement, and healthcare. By reducing the accessibility and quality of healthcare, stigma can drive avoidance or delay of healthcare and non-disclosure of health conditions. This can increase the severity of symptoms and result in higher rates of hospitalization, emergency room visits, and healthcare-related costs. As an example of stigma's economic impact, mental health stigma increases absenteeism and productivity loss in the workplace. It also discourages affected people from seeking healthcare and treatment, which increases costs to the healthcare system in general. Although stigma has been studied in social and health sciences for decades, the research is generally focused on isolated health conditions or social identities. The stigma model can be used to understand individual stigmas while also considering how different stigmas inevitably intersect to create worse outcomes for some people. The stigma model also offers the opportunity to understand the impact of stigma on different health outcomes simultaneously. I'll now briefly speak to how the stigma model might resemble for gay and bisexual people. So, the stigma model will identify the types of stigma faced, for instance, by gay and bisexual individuals. So some of these have to do with the criminalization of same-sex relationships and sexual practices, societal expectations that gender identity matches biological sex at birth. There are gender biases that values men over women, and there's also historical medical diagnosis of sexual orientation or gender identity as disordered. These types of stigma further show themselves up as other social identity stigmas, or can combine with other social identity stigmas, for instance, racism, gender identity, ageism, and these translate into health-related stigmas, mental illness, substance use, and HIV stigma. When all of these various stigmas combine, these individuals can experience on a day-to-day basis, can impact their health. So there are assumptions that an individual's sexual orientation or gender identity, these result in rejection and exclusion from family and peers or community, or lack of alternative gender identities on identification documents, hate crimes and assaults, negative media portrayals, demeaning language. These are all things that these stigma, how they present themselves in day-to-day life. Within a health system, these stigma present themselves as discriminatory interpersonal behavior of the health professionals. It results in the insufficient training of health professionals in issues that have to do with gay and bisexual individuals. It also results in inappropriate practices being considered legitimate medical practices, such as conversion therapy. All of these behaviors at both an individual level and a system level result in various difficulties and challenges with respect to health outcomes. So, for instance, there's decreased social participation, the concealment or denial of identity, the increased risk of homelessness, reduced employment and income opportunities, greater exposure to violence. All of these can also lead to chronic stresses that lead to health-harming coping strategies, for instance, self-harm, disordered eating, smoking, alcohol and substance use. And all of this shows itself in the following negative health outcomes: an increased risk of adverse physical health and mental health outcomes. So, for instance, depression, anxiety, suicide ideation, and suicide attempts. Certain groups of people are feared or seen as less worthy of respect or dignity because of stigma. In combination with other social inequities, groups that are stigmatized are targets for explicit hatred and violence, including physical assault or abuse, sexual assault, bullying, harassment, and hate crimes. Verbal, physical, and sexual violence against individuals or groups can occur at home, in school, in the workplace, in the community, or online. The effort required to deal with stigma reduces a person's psychological resources and resilience. It creates challenges in managing emotions and the ability to self-regulate, and an increased likelihood of having poor sleep habits, using substances, risky sexual behavior, and unhealthy eating. These can place stigmatized people at an even higher risk of acquiring further stigmatizing conditions, for instance, obesity. Although the outcomes may be harmful, these behaviors can be coping strategies and a way to survive challenging or even traumatizing events and experiences. Through this lens, these responses can be understood as normal or expected responses to unjust and traumatic situations. Understanding how stigma manifests in everyday practices in the health system can inform the development of system-wide interventions. I'll follow with some descriptions of some interrelated key drivers and practices that foster and sustain stigma in the health system. Language, for instance, is a powerful tool that reflects and perpetuates biases in society. Words communicate assumptions, values, judgments, and stereotypes that create and reinforce negative portrayals of devalued groups. The way language is used in media, popular culture, health promotion initiatives, education, research, and policy shapes how people understand the world. Using outdated or incorrect language in the health system, such as an inaccurate pronoun or the negative labeling of a particular group, perpetuates stigma and can influence healthcare providers' perceptions of patients. For example, labeling people who use drugs as addicts or junkies marks them as less worthy of care and promotes fear. In another example, describing the illness ahead of the person, for instance using schizophrenic instead of a person living with schizophrenia, contributes to dismissing or demeaning behaviors by healthcare providers during treatment. These types of labels also do not allow for other identities a person may have and suggest that everyone within that one group has the same wants, needs, and challenges. Stigmatizing practices by health professionals may be a result of implicit or conscious bias. Conscious bias occurs when an individual believes and reproduces negative stereotypes and myths about particular groups or individuals, resulting in discriminatory language or practices. For example, a health professional may use demeaning, offensive, or incorrect language in referencing a patient's gender identity or condition, even after the patient has previously stated their preferred terminology. Implicit bias occurs when professionals are unaware that their actions or language is stigmatizing. Commonly held beliefs, stereotypes, and assumptions that pervade society make bias difficult to recognize. For example, Canadians many Canadians believe that there are only two genders, and this assumption is widely reflected in everyday practices such as washroom signage, clothing labels, and healthcare intake forms. Assumptions are generally based on misperceptions or misinformation about certain groups and may influence how a professional examines, treats, and assesses a patient. For example, patients with chronic pain may be denied medication on the assumption that they may be displaying drug-seeking behavior. Lack of training on appropriate care for health conditions or traditional cultural approaches to healing may contribute to the implicit bias of health professionals. Although the avoidance of learning appropriate care is an example of conscious bias. And that today is my discussion.